Hello everyone. This is a case of emergency or rescue encerclage. This is a surgical procedure performed during pregnancy when there is acute risk of preterm labor or pregnancy loss. This is a condition when cervix shortens and dilates and opens prematurely. As in this case, membranes were protruding, but they were not prolapsed. Patient was not in active labor, so we decided to go for cervical encerclage. Cervical dilatation was less than 3 cm. Under low spinal anesthesia was given in lateral position to avoid rupture of membranes, and in this case we planned for modified Shirodkar's encerclage as cervix was effaced and very short, and it was difficult to give McDonald's encerclage. So how to decide whether to give McDonald's encerclage or Shirodkar's encerclage? It is mainly on the length of the cervix. So now you can see that we are preparing for the incision site. At the incision site we are injecting normal saline, plain normal saline, and then the incision was placed on the border of cervix and vagina, and then it was extended laterally. Before that, as you have seen already, that we have put Foley's catheter and we have placed the membranes back to the uterine cavity, and we have kept that Foley's in situ. Foley's was dilated with 20 cc of distilled water, and this is how we are creating the space between cervix and vagina and bladder so that we can reach to the internal os. So it is important in this step not to injure the membranes. And now the stitch is being taken. Actually, I am thankful to my video recorder, as this procedure is very difficult to record. Here we are putting a Marcelin tape, 5 mm tape, which has 2 needles on each side, and now first the central stitch is put, bursting stitch at the 12 o'clock, and the next stitch is between the lateral wall of the cervix. And it as the space is very narrow, it is difficult to put the cervix stitch without we have to put it in the lateral wall of the cervix, but we should not go in the serosal space or in the mucosal space. So this stitch was little challenging. Further we tried little dissection, and then the right side stitch was taken. Afterwards the left side stitch was taken, and then one more bursting stitch was taken at posteriorly 6 o'clock position, and then the knot was tied in the posterior vaginal vault as high as possible. The difference between modified Shirodkar's stitch and conventional Shirodkar stitch, which is we have been taught, is that the posterior knot is kept into the vagina exposed in the modified cervical stitch, but Shirodkar stitch. But in previously we used to bury this knot by incising the posterior vaginal mucosa and burying it and again closing the vagina. But advantage of this procedure is that whenever patient lands up in the labor or patient is going into active abortion, then we can just cut the stitch open and the patient can deliver or abort naturally. So this is advantage of this procedure as compared to the abdominal encerclage. For abdominal encerclage there are very few indications, like previous failed encerclage, because the abdominal encerclage or very short cervix where we can't even put the stitch, because the abdominal encerclage is more invasive as compared to the vaginal encerclage. And also if the patient goes into the labor, active labor or preterm labor, or she starts to abort, then we have to cut open the do the colpotomy and then cut the stitch, or we have to go for hysterotomy. There is no any alternative. So here we have tied the knot, and then we are removing the catheter from inside the uterus. Now we are tying the knot tightly, placing the knot. As this was too much dilated cervix, it was a little difficult to place the knot. So I think we have taken one more stitch on the knot so that the knot should not slip with the mer silk. So whenever we are taking patient for emergency encerclage, we have to make sure that she is not with the ruptured membranes, or she does not have any signs of corium neonitis. That is very important. Also, we have to rule out low-lying placenta and any fetal component like fetal lethal defects. All these things we have to rule out before we take the patient for rescue encerclage. And also it is important that those patients who have previous history of preterm delivery or previous history of abortions or second trimester abortions, so those patients we have to always keep under surveillance, because it's always better that we prevent dilatation of the cervix and beforehand we elective encerclage. If we do, then the results are good. So we have to keep those high risk patients under surveillance from 14 to 28 weeks. Every monthly we have to do sonography and see the cervical length, and so all these things are very important in preventing these kind of complications. Also, there are some complications of this procedure, like there can be cervical trauma, or there can be rupture of membranes while doing the encerclage. There could be a bladder injury, and also there is always anesthesia risk. So, but in this case, it was fruitful, and we were able to do the procedure without any complication. And now here you can see that we are closing the vaginal incision with rapid Vicryl number 10. So it is very important before we go for this kind of encerclage or emergency encerclage, we have to take written consent, informed consent that this procedure we are not giving any guarantee of 100% preventing the labor.